While we are waiting for clinical results of this trial, and there are other trials where people are utilizing T-cell engaging antibodies targeting CD33, CD123, and CLL1, and no results of any of these trials have been published yet. We are very interested in looking at innate and adaptive resistance mechanisms, and we've shown that in response to the T-cell engaging antibodies and the T-cell activation and the secretion of pro-inflammatory cytokines, there's an upregulation of inhibitory checkpoint inhibiting antigens on the AML cells. So we've seen that PD-L1 is upregulated on the AML cells in response to interferon gamma and TNF. And we've shown in preclinical data that we can significantly increase cytotoxicity of the T-cell engager by combining this with an anti-PD-1 or anti-PD-L1 blocking antibody like nivolumab and pembrolizumab. And in the setting of ALL and lymphoma, there are currently clinical trials running that are actually already looking at the combination of a T-cell engager with a checkpoint blocking antibody, which I think is really exciting and is sort of an obvious immune escape mechanism that is going to be addressed by this. The other thing we think, which is really interesting, is combining T-cell engagers with tyrosine kinase inhibitors. So we presented at ASH data looking at the combination of CD33, CD3 T-cell engager with different tyrosine kinase inhibitors. And the importance here is that you have to, on one hand, look at what the tyrosine kinase inhibitor is doing to the T-cell response. So if you are inhibiting T-cell proliferation, you clearly will not have an additive effect, but you need to have probably more selective TKI that is increasing the susceptibility to lysis through a T-cell engaging antibody. And we have some very interesting data to the combination of quizartinib with a CD33 or FLT3 T-cell engaging antibody. Clearly, patients which are not eligible for intensive chemotherapy are going to be candidates for this combination strategy. But I also think that these sort of treatment modules will play a role in consolidation, even in patients that are eligible for intensive treatment strategies. And I think in the long term, it should be maybe the aim to replace stem cell transplantation by a more sophisticated immune modulating therapy.